name's Andrew Reid. I'm an ENT surgeon, and I work in Birmingham. So, for those of you who have only seen Birmingham from the M6, it's clearly the Venice of the North. You're from Birmingham. We have more canals than Venice, despite the fact we're 200 times bigger. And I think that's Venice and I think that's Birmingham. It's difficult to tell the difference on a sunny day. I work at the Queen Elizabeth Hospital, mainly, which was built 10 years ago and is situated in Edgbaston in Birmingham, near where they play the cricket. And I work at Birmingham Children's Hospital, which was built about 150 years ago and has been used as a hospital for various different purposes since then. So both sides of the age of hospitals in England. I'm afraid I can't spare you some basic biology to remind us all of the structure of the ear and how we assess hearing, because it puts in framework the issues of hearing that I'm going to talk about later on. So the first part of the talk may be a little bit tedious to remind people of what goes on in the ear. We'll then talk about problems of hearing loss, how we can manage it. I'm happy to take questions at the end, and I'm happy to take interruptions if I say something that's incomprehensible. I hope that doesn't happen. We've all seen these on the wall of our school classrooms. The outer ear, ear canal, eardrum, middle ear with 3 little bones, and the inner ear with the organ of hearing. And we're going to be talking about the middle ear and the inner ear. And the 3 bones in the ear will concern us. In my language, malleus, incus, stapes. In generic biology language, hammer, anvil, and stirrup, for obvious reasons. And they're small. You can find a picture of a UK currency, but that's a dime. I guess if I'm giving this talk in a couple of years' time in Scotland, I'll have to find a groat or something. It all goes independent.
It'll still be the poo. It'll still be the poo.
And if we look back at the inner ear, the cochlea, it's wound like a snail shell, and it's tiny. There is a 5p, and that gives you the relative size. And if you stretch out the snail shell, you get something that's about 3 and a little bit centimetres long. And packed inside here are 3 fluid-filled canals. And the hearing in the inner ear depends on cells which have hairs on the top. And the hairs move as the fluid moves. So the sound is converted into motion of the fluid, which then converts it into a nerve impulse. And if you take a very strong photograph of the cells, you get 3 layers of hair cells here and 1 out there. And we'll see the effect of that later. So, how do we measure hearing? It's quite important because when it comes to the incidence of hearing loss, it depends whether we're going to measure things. In the UK, all newborn babies have a screening test within the first 48 hours of life, which depends on the behaviour of sound in the ear. So all UK babies for the past 6 or 7 years have had a day 1 or 2 screening test. If that's failed, the child is brought back for retesting, and most of the failures are just due to technical problems of being a 1-day-old baby as opposed to anything else. But as you get older, we require some kind of activity from the individual. So if you're little and you turn your head to a sound, you get a reward, and a dinosaur or a clown lights up in a box on top, and that's how we recognise that a small child has responded. And as children get older, they can do play games. Put the red soldier in the boat, put the green ball in the box. So we're doing hearing tests that depend on the child responding to us. And as children get older, and for adults, we actually shut them in a soundproof box, put a pair of headphones on them, and just say, press the button when you hear the sound, when we control the sounds. And those are the hearing tests we may all have done from time to time. Sometimes it can get very difficult to work out what people's level of hearing is, and it is possible to do hearing tests that measure the brain waves of hearing. I won't bore you with the reasons these aren't quite as accurate, but they don't require the individual to respond. So it's possible to measure hearing in lots of different ways. And when you've done that, you get a hearing test, which goes from low to high frequencies, and you just draw a line on the chart for the responses. And on this side, the blue area gives you the sounds in normal everyday speech. And just to give you an idea of loudness, then this is a baby crying down at about 60 decibels, and you're probably getting me at about 60 decibels through a sound system. A howling dog, a motorbike, and given we're next to Heathrow Airport, an aeroplane down the bottom. So it gives you an idea of the loudness. For those of you mathematically inclined, it's a logarithmic scale. So each of those little squares is 10 times more than the square above. And we tend to then regard hearing as normal, mild, moderate, severe, or profound in terms of hearing loss. And that becomes quite important when we start to look at the incidence, and I'll explain why. We have hearing loss. How do we work out what type of hearing loss it is? Well, hearing loss can be called conductive. If you stick your fingers in your ear, you can't hear what's going on because the sound can't get to your ear. That's a conductive hearing loss. If the cochlea doesn't work, it's called a sensory hearing loss, or sometimes a sensory neural hearing loss. And of course you can have both together, a mixed hearing loss. So just to remind ourselves, conductive hearing loss goes from the edge of the stirrup bone outwards, the orange bit, and the sensory neural hearing loss is affecting the organ of hearing, or the cochlea. Hearing loss is relatively common, and it's important to remember that common causes of hearing loss affect all people in the population. Doesn't matter if you've got OI or not, you still have other causes of hearing loss. Infection is probably one of the commoner causes. The UK population are obsessed with wax, and we spend lots of time cleaning wax out. But actually, wax isn't that common. People just like to have their ears cleaned out for reasons that are beyond me. There is a condition called blue ear, which is very common in children, much more common if you're under 7. At any one time, 10% of children under 7 have blue ear, and 90% of those get better with no treatment at all within 3 months. But there is a small percentage for whom the blue ear persists, gives them hearing loss, because blue means your ear's full of catarrh and it looks like blue, and they may need treatment. So hearing loss in childhood should probably be regarded as glueia until proved otherwise. The commonest cause of sensorineural hearing loss is ageing. My audiogram's got a little bit of high frequency loss. And noise damage, either industrial damage or social damage from music. What about the incidence of hearing loss? And it's here where talking about the assessments becomes relevant. Are we defining as the incidence of hearing loss as the number of people who put their hands up when surveyed and say, I have a hearing problem? Are we defining them as taking a population and screening them all with a hearing test, and then defining anybody at the top of my little chart is fine, everybody else has got a hearing loss? And the answer is, there's a complete mixture. So there's not a great deal of consistency. But if you take the general UK population, these are the figures for the incidence of hearing loss, mostly as reported by people themselves. So it's true to say there might be people who have a mild hearing loss that don't think they do, so don't report it. Yeah.
Do you mean by that that the group that's not shown, 19 to 44, is the other 51%?
Say that again.
You're showing 49% on there.
I'm sorry?
You're showing 49%.
Yeah.
So does the other 51% mean ages 18 to 45?
No, I've just pulled the figures as that. So you mean the 18 to 45s?
Well,
I just haven't got figures for.
Yeah, that adds up to 49%.
What I'm saying is 29% of the over 65s report hearing loss. 2% of the under 18s report hearing loss.
But for the one that isn't on there?
I didn't have the figures.
Right, thank you.
Sorry. So, if we then look at the reported incidence in OI, the incidence of hearing loss below the age of 20 is uncommon. And it becomes difficult to take it out of the glueia type of incidence when you're trying to assess it. But at the age of 50, about 50% of people have a hearing loss, and at the age of 70, it's still about 50%, so that you don't seem to be getting the increase with age. So whether people who were susceptible to ageing changes have had that damage occurring earlier because of something we don't understand in OI, I don't know. But the hearing loss tends to appear from the age of 20 through, with increasing frequency, to the age of 50. So actually, a better way of describing that is that 50% of people at the age of 50 with OI don't have any hearing loss. Why does the hearing loss happen in OI? Well, let's look at the conductive and the sensorineural. This is a close-up picture of the stirrup bone, and there is a disease called otosclerosis, which causes bone to form at the bottom of the stirrup and stops it moving. And that gives you a conductive hearing loss. And if you look inside an ear, can you see that from the back, or do you need the lights down?
It could be a bit clearer if the lights were down.
You know how to turn the lights down. It's over there somewhere. We're going to see this picture again. This is a right ear. That's the first bone of hearing. The second bone of hearing is up there, coming down here, and the stirrup bone sits there and goes away from us into the ear. And where that can't move, it gives you a conductive hearing loss because the bones aren't working. There are reports of microfractures of these bones in people with OI, and there are reports of the bones themselves appearing normal, but actually losing their strength and losing their connectivity. And if you get any fractures, you also get some scarring around the bones, which stops them moving properly and gives you a hearing loss. And if we look for sensory neural hearing loss, there's our 2 layers of hairs. And you look at people with a sensory neural hearing loss, and you see the hairs have died off. It's like someone sprayed weed killer on them. And the problem is, how do we know what's caused that? And the answer is, I'm afraid we don't, either in the general population or in the population with OI. We think that there is some kind of toxic effect caused by an increased bone turnover, but we don't really understand the process. If you have a hearing loss, what are we going to do? Well, the easiest thing to do, and what most people do in the beginning, is improve what in the jargon is called their listening skills. And people do this automatically. They position themselves around a room to get the best sound. They position themselves often so they can see cues when people are speaking, so they can see people's faces. And just learning to listen can be helpful. And we have people called hearing therapists that help people to make the most of their hearing. It would be nice if we've identified the cause, if we could stop it getting worse. But actually, unless the cause is related to you physically damaging it with something like noise, then it's very difficult to stop it getting worse. So we have to say, how are we going to manage it? And the way to manage it, initially, for everybody, is the use of conventional hearing aids. And you say hearing aids to people, and they say, I don't want to wear hearing aids. And these are the sort of things that come to mind. Hearing aids that are very visible, that have all sorts of problems, that are not comfortable to wear. Modern hearing aids are much better, year on year on year, and are light years different to those even of 10 years ago. With a small aid worn behind the ear, small tube, and often no fitting in that part of the ear, because if you've only got a mild hearing loss, you want to get as much natural sound in as well. And when worn, can look like that, or like these. Babies often need a mould in the ear, for reasons I won't bore you with. Hearing aids are problematical. They have technology to reduce the effect of background noise, but that technology is far from perfect. And if people wear specs, then they get in the way and flip on and off very often. So is surgery an option to improve your hearing? My day job is an ear surgeon, and if a hearing aid works, it is the most reliable and it is risk-free. And we were hearing in the talk before about balancing risk in intervention for long bones. You know, if you don't have to put your sense at risk, don't. But there is some surgery that can be done for a conductive hearing loss. And there is surgery for what I call implantable hearing devices. And I'll talk a little bit about both those. I mentioned otosclerosis earlier, and the fact that it mimicked the hearing loss that you see in people with OI. And the surgery is well established, where you take out the stirrup bone and put in a prosthetic bone, or a prosthesis, not a bone. We're back on a 10-cent coin with a stirrup bone there. This is the same picture we looked at before of an ear, and that's a prosthesis that gets put in. The thing you need to remember about prostheses and surgeons is the only way surgeons have got of being memorable is inventing a prosthesis that goes in somewhere. So there are any number of prostheses, all with surgeons' names on, because it makes them feel better. So there are lots of different types. And you take the stirrup bone, you remove it. There's a small hole there that's made into the inner ear. And then you position that metal prosthesis that we saw where the stirrup bone was. And within the ear, it's worth noticing that that bone, that structure, is a nerve that gives you taste to the front 2/3 of your tongue on the same side. And just under there is the nerve that moves your face on that side. And I'll come back to both those later. The operation for otosclerosis gives you complete closure of your conductive hearing loss in 90% of people and is very successful. It doesn't stop the disease otosclerosis, which may actually cause some hearing loss over later years. In people with OI, the initial outcomes are more disappointing, maybe 75 to 80%, which isn't bad. The problem is twofold. One is, of the 20–25% that aren't getting a great result, there's an increased number that gets some of the complications, which can be loss of balance, and can, in a very small number of patients, be what I call a dead ear. So an ear which hears nothing at all forevermore. You could see that that metal prosthesis had a coat hanger hook on. And exactly what you were saying, there is a fear that the coat hanger hook, because the bone isn't structurally as strong as it might be, sits nicely for the first year or so and then eats its way through the bone and falls off. Nobody's done the study to demonstrate that, and it's true to say that happens in normal bones as well. But it is one of the concerns and one of the reasons why what appears to be quite an appealing operation up front is probably not quite as appealing as it might be. So what about if you can't wear a conventional hearing aid and you can't have that operation I've just described? Well, people can't wear conventional hearing aids, sometimes because the outer ear isn't fit to allow them to sit on the ear, but more often because the ear gets infected. Sometimes there are irritation from the plastic in the ear or infections caused by closing the ear if you have to wear a mould. And in those cases, we look at things called bone conducting hearing aids. Slightly odd concept. You take something, put sound straight into your skull, and it transmits itself through the bone into the organ of hearing. Actually, into the organ of hearing on both sides, which you might think would be jolly confusing, but doesn't confuse the hearing system. So how do we do that? You take a titanium screw, fixture in my terms, you screw it in the bone behind the ear, and on top of it, you put a little peg, the jargon is an abutment, and then on top of that, you clip a hearing aid. And those are the two common types of anchored hearing aids, and they drive sound into the head. They're very successful in terms of improving hearing. They're not as good as conventional hearing aids in terms of their technology. And as you might imagine, having a little peg sticking out through your skin can be associated with infection around the peg and can be associated with the skin climbing up over the peg. 4% of those little pegs fall out in the general population, and there's not been enough done in an OI population to be able to give you a hard percentage for the fixture loss. But I'll mention in a minute one of the concerns about using them in people with OI. To try and get rid of the peg, in the last 3 years, people have introduced a magnet. So you have a peg, a magnet on the outside, and a hearing aid. So here, diagrammatically, peg, magnet, skin, magnet, hearing aid. And there's a man wearing it, and there's a man not wearing it. So there's nothing on there to see. And you don't get the complications of skin problems. These haven't been around long enough to know if you get other skin problems in exchange by having a magnet pressing on your skin. But it may well be that these are a way forward to avoid the peg. There are lots of concern that the bone wouldn't be sufficiently strong to retain the peg. It isn't a case of putting the screw in like putting a screw in a wall and hanging something on. There is live bone growth right up to the edge of the screw, and because of those fears, people were reluctant to use them in people with OI. It has now been used on a number of occasions, and actually the reports suggest the fears that they would all fall out is not right, and the retention rate seems to be good. Birmingham, where we've got one of the biggest bone anchored hearing aid programmes, we've done this for 3 children and 1 adult, and they're doing okay, touch wood, so far. But it is a slight concern. Just for completeness, there are other implantable hearing devices, of which these are the trade names, which work in a similar way. But I'm not here to update you on implantable hearing devices of August 2014, but I just mention them in case anybody has heard the names. So what about if your hearing's down the bottom? Because conventional hearing aids can take you down to severe hearing loss. It's probably worth mentioning that the bone conducting hearing aids I've just described really only take you down to moderate hearing loss. They're not good at severe hearing loss. But if you've got profound hearing loss, you're at a point where conventional hearing aids are not strong enough. Your ears don't work. So what can we do there? We can put in a device called a cochlear implant. If I just pass that round, essentially you have a mini computer, a little wire which coils into the cochlea. This is a reference electrode. It's put beneath the skin, above the ear, goes through the bone, into the cochlea and is wound round. And then on the outside, you have to wear something that looks like a large conventional hearing aid. And a magnet which attaches to the inside and inducts energy to the inside. So we think, oh, is that good? Well, it's really only for profound hearing loss. And the reason for that is when you open the cochlea and put a wire inside, you kill off the rest of the hearing. So if you've got hearing, keep it. Don't let people like me put a cochlear implant inside. But if you essentially don't have any hearing, a cochlear implant becomes a good option. Some people who have a cochlear implant can get twitching of the face. And it is well reported that those patients with OI who have a cochlear implant do get more twitching of the face. So let's go back to our old friend, the right ear that we saw in the Stapes operation. We know the nerve that moves the face is running under there. And to put a cochlear implant, which goes into that hole there, we drill down here. And when we drill down here, which is there, there's our stirrup bone, there's the nerve that moves the face, which comes round. We're drilling right on top of the nerve, literally. We often uncover the nerve. And we have to put that inside there, and we believe that the bone, because it's slightly more open, because there's slightly more in the way of blood vessels, the leakage of current outside the cochlea is greater. And the current goes directly to the nerve and stimulates it. If it happens, these implants have, depending on which implant you have, 16 to 20 electrodes, and you can turn some of the electrodes off and try and stop the stimulation. And so cochlear implants are good for patients with OI if they need them, but they do have slightly more problems. What about the future? There's lots of work on regrowing those hairs that we saw that had died away. It appears to be starting to work in mice, animal models, but it's several years away from being used in the general population. And if we understood what caused hearing loss to progress outside of noise, things like that, we could try and stop it happening. But in the general population, we don't really understand what causes most sensory hearing loss. And in the OI population, we don't understand what special factors may be associated with it. So the future may hold something, but we're not sure what. So let's be a bit more positive. 50% of people with OI have good hearing. Conventional hearing aids work well, are freely available, and although they have problems, are good solutions. There's some role for implant hearing aids. And cochlear implants, for the small group of people who have profound hearing loss, can be used. That was a quick run through hearing loss and OI. I apologise, I tried to cover such a wide area, but I hope I've tried to put things in context. And I'm happy to answer any questions that anybody might have.